Hi, everyone, and welcome to ECHO HBV Workshop, Intensive Training for Future HBV Specialists. I'm your facilitator, Rachel Deere with DKBMed. I'm joined by my coordinator, Jill, who also has the same Zoom background, so it's easy to spot her. And always happy to have our faculty, Dr. Calvin Pan, and we have a special guest today with this group, Dr. David Bernstein. Dr. Bernstein, why don't you give a quick introduction?
I'm David Bernstein. I'm a hepatologist at NYU.
So happy to have you here with us for our third module. This is our third of four, so we will conclude this group next week. So again, happy to have you with us, Debbie, Paula, Dr. Samrat, Angel, Minu is coming on. And all right, so I think we've all got our names here. As always, we just encourage people, if they're signed on with another name, just to rename themselves so we can give everyone credit for attending. All right, so as I said, this is our third module. So we're going to be talking about current and emerging therapies. Before we do, we have some quick polling questions. And again, you'll see these again at the end. And as always, if you have any questions about anything, feel free to put it in the chat. And then when it comes time for our Q&A, you can always unmute yourselves and ask a question or put it in the chat and we'll read it aloud. And we'll do that before we get to our case. And if anyone would like to present a case, you have one last chance last week. So we would love to hear from all of you if you've got a case to share. Without further ado, let's launch our Module 3 pretest. Patients with hepatitis B requiring treatment, I initiate treatment with Adefovir. Is that right, Dr. Pan?
Yes.
Okay. Always, often, sometimes, rarely, or never. All right, and question 2, which of the following therapies has the highest rate of developing drug resistance? Tenofovir disoproxil, tenofovir alafenamide, entecavir, or lamivudine? Okay, give everyone a moment to answer that.
Yeah.
All right, so let's end our poll and we'll revisit those towards the end. Okay, Dr. Bernstein, if you want to try to share your screen. If not, I'm happy
share the screen. Okay. So I guess we'll get started. How's that?
Yes.
So welcome, everybody. I again want to thank Dr. Pan for inviting me to join you guys here in this. So today is Module 3, and it's entitled Current and Emerging Therapies for Hepatitis B. The objectives of this session are to appraise the value of emerging and available medications used to treat chronic hepatitis B. And so I guess it's always good to start with the medications that we have that are available, right? And so we have three main classes of medications: the nucleoside analogs, the nucleotide analogs, and the immune modulators or the antiviral medications. And what you can see here highlighted in blue are those medications that are recommended and most widely used. So the nucleoside analogs, that would be entecavir, trade name Baraclude. And then you can see ones that are not used really much anymore: lamivudine, telbivudine, emtricitabine. The reason why we don't use lamivudine or telbivudine anymore is that they really have a high level of drug resistance which develops, with lamivudine as high as 75% in 4 years. So the nucleoside analogs, it's entecavir. The nucleotide analogs, we use one of two. Either tenofovir disoproxil fumarate, which I will call TDF, trade name Viriat, or tenofovir alafenamide, TAF, which has a trade name of Vemlidy. Those are the two standard medications that are nucleotide analogs. Years back, we used Adefovir, or trade name Hepzira, but again, it was a medication where significant resistance developed. So while all these drugs were good initially at decreasing hepatitis B viral loads, over time, resistance developed. With the nucleoside analog and the nucleotide analogs in blue, we really do not see resistance. So these are our first line choices for treatment of hepatitis B. The immune modulators, pegylated interferon, for example, is still available and still effective, given once a week for a year. The issue that we have with pegylated interferon is that nobody wants to take it, because given a choice of a pill every day, even for life, with almost no side effects, and all of the pills that we use are really extremely well tolerated, versus an injection once a week with a whole host of side effects, most patients actually will choose the pills. And so, be interested maybe when we discuss later, Dr. Pan has been able to get anyone on pegylated interferon, but I haven't been for many, many years. In fact, as long as I can remember. When patients develop resistance, you need to change the medication. So if someone is on lamivudine and they develop resistance, the recommended strategy is to put them on either TDF or TAF. That's the same that's true for telaprevir, I'm sorry, where you would switch from TDF to TAF. There is a very small rate of resistance to entecavir. It's less than 1%. And if that develops, well, you would go to either TDF or TAF. For adepavir, in patients that are treatment naive, meaning, lamivudine naive, you could switch to entecavir or TDF or TAF. If they've received lamivudine and are resistant, and then received adepavir and are resistant, then you have to go to TDF or TAF. If someone is on adepavir and the HBV DNA plateaus but doesn't go up, you have a choice. You can either add entecavir or you can switch to entecavir. If someone has a multi-drug resistance, well, this is the patient, and there aren't a lot of them, but we do see some, that you would want to switch to take two medicines, either entecavir plus either TDF or TAF. The good news is resistance has really become less of a problem in the United States, as the majority of medications being used are either TDF, TAF, or entecavir. In other parts of the world where lamivudine and other medications are still used, resistance is a problem. So it's something you really should be aware of. In someone who's taking these other medications and all of a sudden the numbers go up, you should think of really two things. One, they're not being compliant, and two, they're develop resistance. And you can send off resistant panels, which are blood tests that you can send out. So we have a choice now, right? We have oral agents, nucleoside and nucleotide analogs, and we have pegylated interferon. What are the pros then? Why would we want to give a nucleoside or nucleotide analog? First of all, it's a pill, right? So that's patients prefer. Second, it's extremely well tolerated. And third, you see a great response on it. What are the cons? Well, there can be resistance, but the reality is not in practice with the medications we currently see. These patients are generally on therapy for, I tell them, life, because it's really rare to see a hepatitis B surface antigen seroconversion. And we'll talk a little bit about when you potentially could stop. And then there may be questions about long-term safety. TAF was developed after concerns with TDF in patients being on long-term treatment with the possibility of developing bone or kidney disease. So there are some issues that may be there. Interferon, remember the injection, has a finite duration. You take it for 48 weeks. Actually, the best response rates are with pegylated interferon, even over the nucleoside analogs. And there's no resistance. The contraindication is, first of all, it's an injection. 48 injections. And interferon, for those of you who remember using it in hepatitis C, comes with a lot of side effects. Not only injection site reactions, but lots of others. And you have to be very careful in certain patient populations. And you cannot use interferon in patients who are pregnant, in patients who have cirrhosis, and in those who've had a transplant. Whereas you can use TDF in patients that are pregnant, and you can use TAF, TDF, and entecavir in patients that are both cirrhotic and have had a transplant. So, sort of choices. How have we done? Well, over the past couple of decades, with interferon, we see about a 10% surface antigen loss, much improved or better, if you will, than those of the nucleoside or nucleotide analogs. So if the main goal, which it should be, is surface antigen loss, then interferon in the right patient is a really good choice. Although, again, in the United States, patients just do not want to take this. Nucleoside analogs taken for a long time have been shown to delay the progression of cirrhosis, and in addition has been shown to reverse cirrhosis and fibrosis. And this is one of the first liver diseases that we showed that the definition of cirrhosis that Dr. Pan and I learned in medical school, which was irreversible fibrosis, is incorrect. If you take away the stimulus, the liver can actually improve itself. Treatment has been shown to reduce the risk of developing hepatocellular carcinoma, but not eliminate. And since we know the risk of hepatocellular carcinoma is directly related to the viral load, if we bring the viral load down, theoretically, we should decrease that risk. And in fact, we do. We've learned now, and we have the benefit of time, that by using these therapies long term, we've improved patient survival, and we've seen a dramatic decline in the number of patients who need to be transplanted for hepatitis B. Having said all of that, hepatitis B is a disease that we can suppress, but we currently really can't cure. We cure, this says 5%, I would say we cure even less than that. But there may be some patients who are being treated that you can stop therapy on. Hepatitis C, remember, we can cure. So patients always ask, do I have the good one or the bad one? And I never answer that question because I don't believe in those adjectives. But hepatitis C, we can cure. In fact, it's the only viral infection that we can cure. The other main viruses we talk about, hepatitis B, we can suppress. HIV, we can suppress. And even the common cold and its viruses, we can decrease the symptom complex, but we really can't cure those with medication. I mentioned earlier and sort of alluded to long-term complications in patients taking TDF. And those really include mostly bone disease and kidney disease. So in certain select patients, which you can see here, that you're going to start treatment on, those patients who are more than 60 years of age, those patients who have known or suspected bone disease, in particular osteoporosis, or a history of some sort of stress fracture, or on other medications that could potentially worsen bone density. Those are patients who should not be placed on TDF, but should be started on either TAF or entecavir, because those latter two medications don't cause issues related to the bone long term. And the same is true if you look at kidney disease. In those patients with abnormal renal function, with hyperalbuminuria, with low serum phosphates, and those on dialysis, you're really better off using either TAF or entecavir than TDF. The issue which comes up, and it's a sensitive one, is that many of the insurance companies in the United States won't cover TAF. So you puts the doctor or the provider in a position where you've explained to them, the patient, what the best therapy is and why you think one is safer over the other, and then the patient can't get it and ends up with the TDF. Unfortunately, there's not much you can do about that, but I would recommend you document that you had that conversation and that the insurance company denied it. And even when you talk to the insurance companies here in the US, doesn't usually help. On treatment, how do you monitor patients? Well, Monitoring is fairly simple. You're going to get ALTs and you're going to get serum HBV DNA. I usually start patients, repeat labs in 1 to 2 months. Once they become stable, I eventually reach the point that I can see patients every 6 months on therapy. In those patients that are at risk for renal disease, I do get a GFR and I get serum phosphate levels, and I do that in all the patients in particular who are on TDF. So that's how you follow patients, looking for the parameters to see how these medications are working to treat the hepatitis B. Long-term surveillance, you can't forget about, right? Patients with hepatitis B are at risk for hepatocellular carcinoma, and therefore surveillance for hepatocellular carcinoma is recommended. And the recommended surveillance is an alpha-fetoprotein, a blood test, an abdominal sonogram in a thin person, and an overweight person where you can't get a good sonogram, then probably an MRI, would suffice. The questions really become, who do you screen? Certainly anyone with bridging fibrosis or cirrhosis is at a higher risk, but hepatitis B, unlike other conditions, you don't have to have cirrhosis to develop liver cancer. So everyone pretty much gets screened. If we look at response rates then to therapy, right? So I talked earlier about putting patients on treatment. And I talked about briefly viral load. The lower the viral load, the less likely someone is to develop hepatocellular carcinoma. So here you can see here in a study that was published now 6 years ago, that in patients who were treated with anti-hepatitis B therapy, regardless of treatment type, if they had a good virologic response, meaning low levels of virus, they were far less likely to go on to develop hepatocellular carcinoma at 5 years. So it's important that we get patients treated and have low levels of virus. This is another interesting question and one of debate. When do you actually stop therapy? Since most patients truly do require long-term treatment. And when we have that discussion, we have to know what the patient's initial hepatitis B antigen status is. And we have to know their degree of fibrosis. So in patients with cirrhosis, we never stop. We just don't. But in those patients that are antigen positive, that have had a loss of antigen and a development of the antibody, who have an undetectable HBV DNA, who have had that parameters for at least 12 months, you could consider stopping treatment. I can tell you that in my practice, I almost never do, but you can. It's a little bit more difficult in those patients who are antigen negative. Here you have to have a patient lose surface antigen and preferably develop surface antibody and have undetectable HBV DNA for at least 12 months after reaching those parameters. You can consider stopping therapy. And I have done this at some point in some patients. But I'm always afraid when I stop these patients that they're going to have a problem down the road and they may recur. And I have had patients that I've stopped who have recurred. But these are the current suggested recommendations in this patient population. So we survey our patients for hepatocellular carcinoma. As I mentioned earlier, hepatitis B, whether the patient has cirrhosis or not, the folks are at risk for developing hepatocellular carcinoma. It's considered cost-effective to screen patients, and I think we should continue to screen them. And again, that screening is every 6 months. These are the AASLD guidelines for patient screening who do not have cirrhosis. And you can see they're somewhat complex. And so let me just read them to you and then tell you what I would recommend. Asian males with hepatitis B greater than 40 years of age. Asian females greater than 50 years of age. Hepatitis B patients that have a family history of hepatocellular carcinoma, African and North American Black individuals who are more than 20 years of age, and those who are co-infected with either hepatitis C or HIV. It's hard to remember these things. And I don't think you can be faulted to say, I'm going to screen all my patients that have hepatitis B, regardless of age and regardless of race and regardless of gender, with an ultrasound and an alpha-fetoprotein every 6 months. And I'm sure Dr. Pan has as well, have seen many patients, Asian, who have developed hepatocellular carcinoma much younger than 40 or 50. And with hepatocellular carcinoma, the earlier you find it, the better they do. And in the non-cirrhotic hepatitis B patients, if you find a small lesion, they may be resectable. And so I'm very aggressive, I guess, in screening. And I screen all my hepatitis B patients every 6 months with alpha-fetoprotein and sonogram. Hepatitis B drug development has been going on for at least a decade past the approval of TDF and TAF. And several new direct-acting antivirals and other immunotherapeutic agents are in development at various stages. And there are a lot of potential theoretical medications that could be available. They fall into several classes: those that inhibit replication, those that reduce antigen levels, and those that stimulate the immune system to fight against the hepatitis B virus, and all sorts of combinations. So it's 2023. We're almost halfway through the year, which is amazing. And there's nothing on the horizon in the near future that is going to replace what we currently have. There's a lot of work being done. There's a tremendous need to develop a cure for hepatitis B, similar to what we've developed for hepatitis C. But we're just not there yet. And the reality is we're not even close. So I apologize, for that. Here's just an example of some of the medications that are being studied. They're all early. Many of their similar types of medications have come and gone in early studies, but we'll have to see. I'd like to remain hopeful that we will develop something, but hepatitis B is a tricky virus. It's very complex, and because the hepatitis B virus integrates itself into the DNA in the nucleus of the hepatocyte, into what's called the cccDNA, it's very difficult to actually get rid of hepatitis B, which is why we know patients that had hepatitis B got over it, have immunity, and then are placed on immunosuppression and have reactivation many, many years, even decades later. So hepatitis B is tricky as we go forward. Go on to Dr. Pan.
Thank you so much, Dr. Bernstein. Dr. Pan, any comments?
To hear from the group, are there any questions regarding this presentation? And thank you, Dr. Bernstein, for fantastic explanation, all those treatment options and the newest developments. Any questions about the content need to be clarified?
Feel free to put any comments in the chat and we could read those aloud.
Well, people are either sleeping or
maybe in the middle of lunch.
or self-explanatory.
I have a couple questions that came up because we meet with another set of folks on Tuesday. So I'm just going to put those questions in the chat for Dr. Pan, Dr. Bernstein. And again, if anyone thinks of anything else, let us know. So I put the first one in. How common is it that people can stop NA therapy?
I think it's pretty uncommon that you can actually stop. Probably less than 5% of the patients that we treat. And so therefore, the discussion, I think the hardest decision point in hepatitis B treatment is deciding on treatment, because once you make that recommendation and decide on treatment, you're in for the long term. So I don't know what Dr. Pan thinks, but to me, it's uncommon that we can stop many people.
I agree, David. You mentioned 5% actually is even shooting for 5
Probably
years.
lower, right?
Yeah, 5 years for
Yeah.
common first line antiviral treatment is about 5%. But if you really want to put your patient through interferon with side effects, it could enhance the surface antigen loss somewhere between 8% to 16% in 5 years. So at the end of first year treatment, it's 8% in their pivotal trial, and follow-up for 5 years is 16%. So that's why we need more new agents, more different target antiviral treatment through the HBV life cycle to get a better efficacy, which is around the corner. Probably in the next 3 to 5 years, you will see at least 2 to 3 new agents, different targeting point, can do a combination, can drop the surface antigen to a detectable level we call clinical cure. So yeah, it's not uncommon. So that's why the current strategy is put the patient on long-term treatment. However, if you still think about interferon therapy, not at the beginning as a de novo treatment, but as an add-on or switching to the antiviral treatment, in a selected group of patients, we're talking about surface antigen level less than. Sorry about that.
There we go.
Was some technical issue was disconnected. So we're talking about in selected group of patients with surface antigen titer less than 1,000. Or preferably, if less than 100, you don't even need to worry about them. You can just stop the treatment, and they will do better anyway. If less than 1,000 or 1,500, depends on what study you're looking at, adding on interferon or switching to interferon between 6 months to a year actually can increase the surface antigen loss about to 30 to 40%, which is 1/3 of them. So those are the options for selected patients. That's the best we can do by far.
Thanks, Dr. Pan. Okay, and I have another question to share from our other group. What happens after interferon therapy? Do people need to go on NA, or is IFN therapy ever repeated?
I can answer to that. Probably you should monitor those patients closely. Even interferon treatment is phenyl treatment, but some of the patients even achieve surface antigen loss. They could potentially return to have viremia level. Few of them may reverse whatever clinical outcome you have achieved. So in case they get reversed, you definitely can put them on antiviral treatment, oral treatment. Eugene Shi, for many years ago, he's our godfather for gastro and hepatology. He did a larger study looking at putting patient back on oral antiviral can achieve similar outcome as you would expect it. As those patients started with de novo antiviral therapy. So monitor, put them on if they need.
Yeah, so I think I agree with Dr. Pan. It really depends how the patient does. There will be a small subset of patients that lose surface antigen, and you don't have to put them anything back on, and you do need to continue to monitor. And then there'll be those who didn't have a response, and then you'll put on the NAs. So I can say I like that Dr. Pan quoted Dr. Schiff, because he trained me and I worked for him for a long time. He would try to convince patients, mostly unsuccessfully, to take interferon for a year, but present it as, you can take it for a year and there's a high likelihood that you won't need treatment afterward. We'll have to monitor you. And if for some reason it didn't work, we'll just put you on the therapy without really harming you other than side effects. And so I think that's actually a good way to approach these patients. The problem in the United States is most patients just don't want interferon.
I know, maybe in the future, there are some better interferon, not that much about the efficacy, but less side effect and safer, like albumin or lambda interferon.
Lambda, yep.
That might be bring up the level of interest in using interferon. Personally, I'm still a big fan of in combination of immune enhancers or immune modulators. I think it would offer you a better durability after you achieve the clinical endpoints.
Any questions from the group? No? Okay. I think we'll move on to the case then, Dr. Pan.
All right. This case 3 is 27-year-old patient have been diagnosed with hepatitis B during a routine physical exam, just newly diagnosed about a week. So he was seen by a primary doctor like 4 blocks down the road and heard that you got involved in hepatitis B a lot. So he wants your second opinion. Now, you asked for a blood test. He showed a blood test report about a week ago, surface antigen positive. As you review the module 1 contents, you know this is a hepatitis B infection, and E antigen is negative. That means patient might have a mutation. They may have gone through the high viremic stage, so-called immune tolerance. Now the new concept is called immune inactive, E antigen positive. So he gone through that. Now he's a E antigen negative with a significant viral load, right? We review the module 2 talking about treatment selections on patients with viral load more than 2,000. So he fits in that criteria. However, normal liver function, ALT was within normal by the lab. Does it need antiviral treatment? That's his question. And before we move on the next, I want to hear from the group. Single question is, you got this lab, young people, but normal ALT, would you want to put him on now? Any takers?
You could put it in the chat and I see Dr. Naidu, you have a question. We'll address that. No takers, Dr. Pan.
All right. So I would
Give my
share.
opinion.
Okay.
I'll give my opinion. Right?
Sure.
So based on the criteria that I guess you learned earlier, this patient would not be a candidate to start treatment at this time, because you need an e-antigen negative patient. You need someone whose HBV DNA is more than 2,000 and has an abnormal ALT. Having said that, I would do I would remind people what a normal ALT is. And so in a 27-year-old, we don't know that this is I guess it's a he, right? So it's a man. Normal ALT is up to 35. And many of the labs are up to 40 or 45. So if the ALT is abnormal, if it's 38 or 40, it's actually technically abnormal. So I would look at that. And then I look at 3 parameters. I look at viral load, I look at ALT, and then I look at degree of fibrosis. And so I like to get transit elastography or do a FIB4 test and then make a determination. If there's no fibrosis, I wouldn't treat. If there was significant fibrosis, I would treat. And so I add that into my mix, although I tend to be fairly aggressive in these hepatitis B patients. I don't know how Dr. Pan feels.
Yeah, David, you are 100% adopting the current standard of care. I have no argument on that. And this patient, I just want to bring up the message of, I totally agree with Dr. Bernstein's approach. But I want to add on, today, patient, they are not qualified for treatment doesn't mean tomorrow they won't. First of all, definitely like Dr. Bernstein mentioned, based on these 3 things, surface antigen, 2400 DNA, normal ALT, if you think it's absolutely normal, below 35. So you're not there yet, but further study, further evaluation of the other risk factors for disease progression of cancer risk should probably offer you a more accurate decision and manage the risk of disease progression of cancer. That include all those measurements or tests Dr. Bernstein mentioned. But even hypothetically, if you get all those report back absolutely normal, there is no red flag, I still want to emphasize that this kind of patient needs to be close monitoring. How close? I will recommend every 3 months, because later on when you read through the case, you'll find that the ALT today is normal, tomorrow may not be. They could be activated. Even though it's 27-year-old, particularly in E antigen negative patients, very standard, very traditional study done by Derry Lau in Harvard before she was in NIH observed the E antigen negative patients for 1 year without treatment. At least 1/3 of them have intermittent elevation of ALT that you may not catch that in one single test, or test of patient infrequent. Infrequent, that means more than 6 months. So monitoring is a key if you don't think the patient is fitting the profile now for treatment. Now, further down, like Dr. Bernstein just mentioned, look for the other risk factors. And you ask a patient, what happened to his family? And he said that, well, my father and my brother actually have liver cancer, and father died from liver cancer in early stage, early age. So would that change your decision-making process? Would you treat this patient at this point? Anybody?
If no one goes, I'll go.
All right, we'll circle back to you, David.
So when you add in that parameter that the patient has 2 family members that develop liver cancer, as I mentioned earlier on in the discussion, I would put this patient on therapy, because family history is a determinant. And the presumption is if father and brother have it, this is maternal fetal transmission. And whatever this virus is similar. And I would put this patient on treatment now with those parameters and that history.
Yeah, that's 100% perfect decision. In the AASLD guide, I actually emphasize that first degree relative with cancer from HBV associated cancer, particularly in early stage, serve as a very significant risk factor for future development of cancer in this case. And also the Asian American algorithm suggests that family history is a predetermined risk factor enter the patient for treatment. So there is no doubt, even under the current recommendation for the guideline and consensus, you need to treat this patient. But a quick question would be, what antiviral treatment you want to select? Let's say if a patient said that I don't have legal status, I'm an illegal immigrant, I don't have insurance. I heard that my friend actually from Asia, they can get lamivudine, very cheap. Can I ask them to mail lamivudine here? Because the first line treatment I cannot afford in the United States. Would you agree with him to take the lamivudine at this point?
You're asking me or you're asking the group?
I would ask the group first.
Oh, good.
Group,
I
but I
know you
think
know the answer.
you'll have to be ready with
You
an
know
answer.
the answer. I want to give them a chance to talk about their opinion and their real experience, if they have that experience. What's the difference between a second line and first line treatment? Is it because their efficacy difference or their safety? Or both? Anybody? So if nobody volunteer for the answer, let me ask David, if you compare first line and second line, do you worry about the efficacy, safety, or both?
You know, I worry more about resistance. So I would call that, I guess, the safety and efficacy.
Yeah,
Right?
both.
Yeah, so both. You know,
What's the difference?
I would listen to this guy talk, but and I would have empathy for that. But the problem is that the person's young and most likely has more mild disease and is going to develop problems further down the road. And you're giving lamivudine, which you know in 4 to 5 years, you're going to have resistance 75% of the time. And so I would really discourage him from taking that as a stopgap measure, because it always becomes a little bit more difficult to treat these patients after they've developed resistance from one treatment. But you really brought up a very difficult and question, right? Because these medications are very expensive. And can you substitute something that's far lesser with risk for something that works well? And so that's a real social determinant question. But I, as a top line response, would discourage lamivudine and try to find ways to get one of the other first line agents that are available.
Dr. Pan, I was just going to
Go
read
ahead.
Dr. Nadu's comment in the chat. I will worry about both, especially if they develop resistance from a specific treatment.
Right.
Yeah, absolutely.
So my opinion is absolutely should discourage and try to persuade patient not to use it. Maybe patient was misinformed. They thought that lamivudine used to be very cheap. But now, even in United States, the first line treatment like entecavir or tenofovir DF, it's a genetic now. And their price is not different that much. Almost some of them even lower in certain area compared to lamivudine. So there is no reason. I think the patient might still stay in the old concept of lamivudine because at that time entecavir or tenofovir is still under the brand, have the patent. But now even in United States, both of this first line is genetic. And genetic medication very affordable, $10 to $20 a month. You can take care of that. So definitely I would vote against using lamivudine. As Dr. Bernstein just mentioned, lamivudine is the worst drug in terms of efficacy and safety. Safety is the highest resistance, as you have a pre-test question as which medication among all the second line. Second line all have resistance. Second line include lamivudine, tavipudine, and adefovir. They all have resistance. And first line, only entecavir have very, very small frequency of resistance. For treatment naive patient, less than 2%. But for lamivudine, it's like 1 year 30% and 5 years 70%. So it's a horrible drug. Do not use lamivudine anymore. There is no reason. I think even in the United States, given the option of genetic first line, do not use lamivudine for your patients.
And Dr. Nadu said in the chat, TDF is the first line in South Africa currently.
Right. Even outside the country, TDF have been not only genetic, but can be a genetic with the huge discount price to the resource limited area, just like the other doctor mentioned that the government usually get the order tender with very, very low price that's sent by the Indian genetic company that they can sell to them by volume. So even TDF in most developing countries with source limited, they sell for about less than $5 per month, which is quite affordable. All right, so let's move on the case. You decided to offer this patient treatment because of family history. Now, if a patient have a urine protein 2+, but the kidney function is relatively normal, just a proteinuria, how would you explain in this case? Would you change the treatment? He's nervous. He has, can my proteinuria could be improved with the Hep B treatment? What would you say to him?
I direct that question to you, Dr. Bernstein.
Okay. I didn't even get to see these in advance. So this is a patient with Hep B who has proteinuria, right? And that proteinuria can, come from a complication of hepatitis B, and it could come from underlying kidney disease. Regardless, in my opinion, in someone that has any potential renal issues, I would not want to start this patient on TDF, but would give them either TAF or entecavir. as a treatment. So that would be my advice, because there's a risk long-term in TDF of worsening kidney disease. So that's what I would recommend. I don't know, Dr. Pan, what do you think?
Yeah, I would agree. You try to avoid potential harm by the medication side effect. You definitely can choose even entecavir or TAF to treat this patient, but just try to answer the patient whether the HEPI treatment will improve the proteinuria. I'll say at this point, probably we're not sure. There are chances that the HEPI treatment can improve if the proteinuria is from the extrahepatic manifestation of hepatitis B. Commonly happen is the HEPI surface antigen or E antigen. In this case, mainly the surface antigen with the immune complex deposits in the kidney. It can cause glomerulonephritis or proteinuria due to the damage to the kidney's tubular function, leading to protein leaking out from the tubular. So we're not sure yet. We need to do some investigation and see this is actually fitting the profile of HEPI-induced complication like David just mentioned. But there might be a chance to improve. We have seen patients have kidney problem due to HEPI per se. Using antiviral treatment, they can improve the outcomes. All right, so let's move on. During the treatment, you decided to offer entecavir, or unlikely, I will offer TAF because TAF is still expensive in United States. If you're outside United States, you're in Africa, TAF is part of the HIV regimen, you may get it cheaper. You couldn't tell the difference, then you can use either one. So in US, I just based on, because many of you are practicing in US, I would ask these patients use entecavir. It's very affordable. And also treatment naive patients running into drug resistance with entecavir is very, very infrequent. So I think I can start with entecavir, consider the kidney issues, affordabilities, and also first line. However, patient have ALT 187, AST 200 after you start the antiviral treatment. What do you think what's happening to this patient? Or if you're not sure what kind of tests you want to do. Today we got a very quiet group.
Yes.
Yes.
For trial, or Dr. Herschel, Naidu.
Dr. Naidu, I know you're active in the chat. You
Could
asked
you
it.
give
Oh,
us
you said
your
a couple
insight
things.
on this? Or
Yeah.
your opinion?
No, I don't think we're gonna get it, Dr. Pan.
All right,
Got
so
nothing.
maybe I will ask David what he would do. Dr. Bernstein, what would you do in this case?
So
Once
this
you
is,
would
so as
pick-
far as I understand, this patient started on treatment,
Right.
and now how long into treatment is this up?
This is about 2 months later, because you asked him to come
Yeah.
back for follow-up in 2 months, your initial, let's say, entecavir.
You know, what could this be? You know, you're
I think you have a very thorough analysis on this case. I couldn't do much more than that, but I would go by the frequency to eliminate the possibility. I think I agree with you. The number one is medication compliance. The study have shown that the number one clinical deteriorating in HEPI patients if non-compliance, including viral rebound, ALT elevation, or even jaundice or whatsoever, and related to hepatitis B. So a patient just take about a week or 2 weeks medications and they stop, then actually can cause viral rebound or even higher than 25 or 2400. ALT can deteriorate, sometimes they get jaundice. They can really even get worse than before. So medication compliance or adherence is the number one, higher frequency than the others. Number two would be, if I want to look for most patients that I see, the number two reason is the lab error or the other things that affect the ALT rather than hepatitis B. For example, oftentimes now the summer is coming, if your blood test, you draw the blood test in your office, if dump it outside your office box, and the laboratory usually pick up at the end of the day, and the specimen could be deteriorated or totally unuseful, exposed to a high temperature or improperly handling. So Dr. Bernstein mentioned that repeat might be an option, providing that patient is clinical stable, you don't see jaundice, you don't see any acute picture going on, and just the number abnormal. Of course, we want to go through, whether a patient is taking, many of happy patients in United States are Asian. Common things, the other factors affecting the ALT is herbal medication, particularly early on when they are starting a viral hepatitis treatment, and they thought that, the more things will be more helpful. They may see traditional herbal medication, traditional Chinese medicine practitioners and simultaneously start herbal medication that can check up the ALT. Some of the other things, like NAFLD, NASH, is commonly you can find out a patient gaining weight. So the second most common thing, bottom line, is either measurement is not correct or drug-induced ALT elevation. If you want to narrow down, would be entecavir causing it? Yes, there is a 5% on their clinical trial, phase 3, called on-treatment elevation of ALT. Dr. Bernstein mentioned that, on-treatment from entecavir. But more likely, you want to rule out is the drug-induced ALT elevation from the other drugs. Are there patients just recently taking herbal medication? That should be on your radar. Because I wouldn't imagine a 25-year-old all of a sudden started on anti-lipid aging. For example, sometimes the statin can get you an elevation ALT like that. But in elderly people, that's also on your differential risk, and see if they start the other medication can elevate the ALT. Then you're going down the road and think about entecavir resistant. I think it would be a lower priority because of frequency. I hope those things would help you to manage your patient.
Thank you, Dr. Pan and Dr. Bernstein. Just want to mention, Doctor, I had some comments. Please check to see if it's not drug-induced and check all panel screening again. Also check compliance of the patient. Okay, so you saw these questions at the start, and I know we ran a little over, so thank you everyone so much for sticking with us. As a result of this activity, how confident are you now in discussing appropriate hepatitis B treatment? Much more confident, moderately confident, somewhat more confident, and not more confident. And again, we've got our fourth and final session next week. So if you are not much more confident, we're sure it will increase as we go along. And then question 2, which of the following therapies has the highest rate of developing drug resistance? Tenofovir disoproxil, tenofovir alafenamide, entecavir, or lamivudine. Okay, and as you're answering, Jill will put the link to the evaluation in the chat as a reminder. Okay, so it looks like we're definitely more confident, which is great. Question 2. Most said lamivudine. Dr. Pan, what's the correct answer?
How many of them actually chose this?
83%.
Wow, I think your group are doing better than another group, right?
They are, except the other group is chattier. So, all right. And we know that next week is approaching a holiday weekend, so we do hope that you can join us for next Thursday, same time. Thank you, Dr. Bernstein, so much for joining us this week. It's been a pleasure. Everyone else, thank you so much. Echo clap. We will see you next time. Any questions, feel free to reach out to us anytime. Thank you so much.
Thank you,
everyone.
David. Thank you.
Bye-bye.
Take care.
Bye.